Now for our last topic for today, we will be learning about the herpes virus infections. And in order to make it a bit more interesting and different, we will have a question and answer or a Q&A lecture. Now what are herpes viruses? They are double-stranded DNA viruses that have the ability to produce latent, lifelong infection by infecting immunologically protected cells such as immune cells and nerves. Infections with herpes viruses may be either asymptomatic, first episode, or recurrent type. The first episode or primary infection with herpes viruses tend to be more severe and more extensive than recurrent episodes. And recurrent disease, on the other hand, tends to be milder and of shorter duration. Now let's start with herpes simplex. Our first question is, how would you describe the lesions in a herpes simplex infection? Are they discrete widespread vesicles measuring 1 centimeter in diameter on average? Erythematous papules in linear arrangement on the skin? Grouped pinhead-sized superficial vesicles on an erythematous base? Or grouped superficial pustules on an erythematous base? And the answer is, they are grouped pinhead-sized superficial vesicles on an erythematous base. Herpes simplex infections in general do present in a very similar manner. They appear as acute, self-limited eruptions of grouped pinhead-sized vesicles on an erythematous base. And the onset of the appearance of these lesions is usually preceded by a localized itching, burning, or pain 1 to 2 days prior to the appearance of the vesicles. Herpes simplex viruses present in a variety of ways, and for our discussion today, we will learn about these 4 types of herpes simplex virus type 1 infections, namely Herpetic Gingivostomatitis, Herpes Labialis, Herpes Gladiatorum, Herpetic Whitlow, and the herpes simplex virus type 2 infection, genital herpes. Next question. What is the usual age of a patient with primary gingivostomatitis? Is it 5 months, 5 years, 25 years, or 50 years? The answer is 5 years. Herpetic gingivostomatitis is the first episode or primary infection with herpes simplex virus type 1. It is seen in young children between the ages of 1 and 5, and the disease ranges from a mild and inapparent infection to a severe one with high fever. The lesions of herpetic gingivostomatitis are seen within 5 to 10 days from exposure to an infected adult. Herpetic gingivostomatitis starts as fever, sore throat, painful vesicles and erosions on the tongue, palate, buccal mucosa, and lips. Drooling, halitosis, inability to eat, and lymphadenopathies are included in the symptomatology. It being a primary infection, it tends to be more severe and longer in duration. So much so that this eruption will last, or this illness will last, for 1 to 2 weeks. Next question. What is the usual site of infection for herpes labialis? Is it the labia majora, the vermilion border, the buccal mucosa, or the gingiva? And the answer is the vermilion border. Herpes labialis is the recurrent form of herpes simplex virus type 1 infection. It is also called the cold sore or the fever blister. It manifests as grouped blisters on an erythematous base on the vermilion border of the lips, and the vermilion border of the lips, as this arrow indicates, is where the skin and the mucosal area of the lips meet. A prodrome of tingling, itching, or burning may precede the outbreak of these vesicles. Herpes labialis can be triggered by sun exposure, trauma to the lips, stress, or fatigue, or any other reason by which a patient might become immunodeficient. These lesions, being a recurrence, heals much faster, and they tend to heal spontaneously in 4 to 7 days. Next question. When herpes simplex type lesions are seen on exposed areas of the face and extremities, what do you think is this infection called? This infection is called Herpes Gladiatorum. Herpes Gladiatorum is an HSV-1 infection that is seen mainly among wrestlers and other contact sport players. It is transmitted by direct skin-to-skin contact with an infected athlete who has active orofacial herpes but still insists on playing the game. The sites of the lesions for this particular type of herpes simplex infection is not very typical, such as the neck, the side of the face, or the forearm, or any other part of the body that might have come in contact with active herpes labialis lesions. Vesicles appear 4 to 11 days after exposure. Next question. Who are at risk for this kind of herpes infection? Would it be dentists, office clerks, bank tellers, or physical therapists? And the answer is dentists. This type of HSV-1 infection is called Herpetic Whitlow. It is the primary or recurrent herpes infection of the finger. Medical and dental personnel are at risk for this type of HSV-1 infection. It can occur through auto-inoculation by touching an active lesion, let's say in the mouth of a patient if you are a dentist, or even by nail biting. Next question. Which among these is a picture of primary genital herpes? Now, looking at these two pictures here, since primary infections tend to be more severe in appearance and duration, then the answer would be letter B, where the lesions seem to be ulcerating, as opposed to letter A, where the lesions are only vesicular. Now that was a picture of primary genital herpes. Primary genital herpes is spread by skin-to-skin contact, usually during sexual activity. The incubation period for this disease averages about 5 days. It begins with a small group of vesicles that ulcerate in a few days, and of course you know where they're usually located. The first episode of genital herpes will tend to be more severe, with multiple bilateral and larger lesions. And is associated with painful lymphadenopathy. In fact, the course of primary genital herpes may last up to 3 weeks. Next question. Which among these will last for 8 days and heal without scarring? In other words, which among these is a picture of recurrent genital herpes? And the answer is picture A, since the lesions here seem to be less extensive and less ulcerating compared to the lesions in picture B. Recurrent genital herpes tends to begin with a prodrome of burning, itching, or tingling in the area where the vesicles will eventually appear. The blisters form within 24 hours of this prodrome of sensation, and the average duration of the outbreak is only 7 days. And the lesions do not ulcerate and tend to heal without scarring. Now let's talk about diagnosis of herpes simplex virus infections. Here in this picture, we see a slide with this large bluish cell. Here's the question. These findings are specific for herpes simplex infection. Is it true or is it false? And the answer is false. That slide was a slide of a Zank smear. Now, the Zank smear is the most common method of diagnosis for HSV infections. It is rapid, but it is nonspecific. Why? Because the presence of multinucleated giant cells in both HSV and Varicella Zoster infections are seen. So it's not specific just for herpes simplex virus infections. It is not very sensitive either, because it is positive in only 60 to 70% of cases. Now, what about treatment? Acyclovir is the prototype drug for the treatment of herpes virus infections. How does it work? It induces an enzyme called thymidine kinase, which forms acyclovir triphosphate, which is a powerful inhibitor of viral DNA synthesis. The treatment dosage for this particular drug is dependent on the type of herpes virus infection that it wants to cure. So next question. What is the dose of acyclovir needed for the treatment of primary genital herpes? Is it 400 milligrams twice a day for 1 year? 200 milligrams 5 times a day for 5 days? 800 milligrams 5 times a day for 7 days? Or 200 milligrams 5 times a day for 7 to 10 days? And the answer is 200 milligrams 5 times a day for 7 to 10 days. For recurrent genital herpes, the duration is much shorter, at 200 milligrams 5 times a day for 5 days. For varicella and herpes zoster, the dosage is much larger at 800 milligrams 5 times a day for 7 days. And for suppressive therapy, for very recurrent genital herpes, the duration is much longer at 400 milligrams 2 times a day for 1 year. Now let's move on to varicella. Question. These statements are true of varicella, except it is caused by VZV. It is the primary infection with this virus. It is primarily a disease of children. Its incubation period is 7 days. And the answer, or rather the wrong statement here is, its incubation period is 7 days. Varicella is the primary infection with the Varicella Zoster virus or VZV. It is primarily a disease of childhood, and the appearance of the lesions may be preceded by 2 to 3 days of fever and flu-like symptoms in older children and adults, although in younger children, they don't feel any symptoms at all. The incubation period for varicella is much longer than 7 days. It's 10 to 21 days. And it's important for us to remember this because as doctors, we might be exposed to people with varicella, and knowing that the incubation period is 10 to 21 days, it's only after maybe about 3 weeks after our exposure that we can truly say that we did not contract varicella from that patient. Next question. How would you describe the lesions of varicella? What do they look like? Are they discrete, superficial, thin-walled vesicles on an erythematous base? Do they have a central distribution with relative sparing of extremities? And because the vesicles appear in crops, do the lesions eventually have a polymorphous appearance? Or are all of these statements true? And the answer is, all of these statements are descriptive of the lesions of varicella. A varicella eruption is mainly vesicular, and the lesions are superficial, thin-walled vesicles always on an erythematous base, so much so that they have been described as dewdrops on a rose petal. The lesions do not always stay vesicular. They progress rapidly from papules to vesicles to crusts. They are distributed in what we call a central distribution, meaning the vesicles form first on the trunk and spread peripherally to the face and the scalp. And as they spread more peripherally to the extremities, less and less lesions appear. So much so that they are distributed in what we call a central distribution with a relative sparing of the extremities. Now, the successive crops of vesicles developing into crusts over several days, and not all at one time, eventually lead to a polymorphous appearance of lesions where you see on the patient's skin a mixture of vesicles, crusts, scabs, and pustules, all at one time. What is the most common complication of varicella? Is it pneumonia, encephalitis, glomerulonephritis, or secondary bacterial infection? And the answer is secondary bacterial infection, because indeed the formation of pustules on the patient's skin is even part of the normal course of this disease. Now we go to herpes zoster. Question: how does herpes zoster occur? Does it occur as a reinfection with the varicella zoster virus? Is it a sexually transmitted disease? Is it a reactivation of latent varicella zoster virus? Or is it a primary infection with the varicella zoster virus? And the answer is, it is a reactivation of latent varicella zoster virus. Herpes zoster is actually the recurrent form of a VZV infection. And how does it happen? Well, during active varicella, VZV passes from the skin lesions into the sensory nerve endings, particularly in the dorsal root ganglia, where they remain latent for years until the host resistance falls. When that happens, the virus gets a chance to be reactivated and replicate again within the dorsal root ganglia, causing its inflammation and neuralgia. Eventually, by its continuous replication and by axonal flow, these viruses are released at the nerve endings, causing vesicle formation, but only in the skin that is innervated by that particular nerve. So which among these is characteristic of the rash of herpes zoster? It affects adults over 50 years of age in most cases. The appearance of the rash is often preceded by pain and paresthesia in the area a few days prior. It is dermatomal in distribution. Or are all of the above statements correct? And the answer is all of the above statements are correct. The herpes zoster rash is a unilateral eruption of grouped vesicles on an erythematous base. The lesions occur within a band of skin following a dermatome that is innervated by a particular dorsal root ganglion. Similar to varicella, successive crops of vesicles developing into crusts eventually lead to a polymorphous appearance of the lesions. But, as you can see, it is only limited to a particular band of skin. Now let us familiarize ourselves with some special forms of herpes zoster. Question. In this form of herpes zoster, there may be vesicles in the cornea. A clue to this involvement is the presence of vesicles on the tip of the nose. Is this Herpes zoster ophthalmicus, Ramsey Hunt syndrome, or disseminated herpes zoster? The answer is Herpes zoster ophthalmicus. Herpes zoster ophthalmicus is herpes zoster involving the ophthalmic division of the trigeminal nerve. And because it is this nerve that is affected, the vesicles are located on the upper one-third of the face unilaterally. Aside from this, vesicles may appear on the side and tip of the nose. This is due to the involvement of the nasociliary branch of the trigeminal nerve, and this particular appearance of vesicles is known as the Hutchinson sign. Hutchinson sign is a very important sign because if you see this, it might also indicate eye involvement in the form of uveitis or keratitis. Now, what is Ramsey Hunt syndrome? Ramsey Hunt syndrome is herpes zoster involving the facial and auditory nerves, and it will manifest itself as an ipsilateral facial paralysis without any cutaneous lesions on the face. It may be associated with the appearance of vesicles on the external ear or tympanic membrane, also known as herpes auricularis, due to the involvement of the auditory nerve, and auditory symptoms like tinnitus, deafness, vertigo, or nystagmus may occur. Disseminated herpes zoster refers to herpes zoster wherein, aside from lesions in the affected dermatome, there are 20 lesions or more outside of this affected dermatome. It occurs mainly among old, debilitated, and immunocompromised individuals, and because they are immunocompromised, these lesions may progress from being vesicular to becoming hemorrhagic or even gangrenous. Question: what is a complication of herpes zoster characterized by long-standing pain? Is it viral myocarditis, secondary bacterial infection, post-herpetic neuralgia, or pneumonia? And the answer is post-herpetic neuralgia. Post-herpetic neuralgia is the most troublesome symptom of herpes zoster. It's the tendency to have this complication of herpes zoster is actually age dependent. Patients older than 60 years who develop herpes zoster will experience, half of them will experience pain even 1 month after all the lesions have healed. Patients who are older than 70 years, on the other hand, 75% of them will still be experiencing pain 1 month after all of the lesions have healed. And this type of pain, this post-herpetic neuralgia, is a pain that may persist for months to even 1 year. However, it's important to note that early and adequate antiviral therapy will decrease the risk of prolonged post-herpetic neuralgia. That's why it's very important to treat adequately and treat early any elderly patient who develops herpes zoster. Thank you for listening, and I hope you enjoyed this Q&A session.